All right, why don't we go ahead and get started with today's grand rounds. So I'm Adrian Hernandez, today's moderator for our grand rounds here. And we're really pleased to have Derek Russell from UAB and Matthew Semler from Vanderbilt, who are going to present the Prepare 2 trial, embedding a pragmatic trial into clinical care during an emergency procedure. It seems quite easy, and so really look forward to your presentation and discussion here later. Thanks for joining. We'll go ahead and turn it over to you.
Great. Thank you so much for the invitation to join you all at the NIH Collaboratory, and we appreciate all the work that this group is doing to support pragmatic trials and build this community. And again, I'm Matt Semler from Vanderbilt, and Derek Russell is here from UAB, and we'll be kind of splitting this talk. And he and I are here today representing our Pragmatic Critical Care Research Group, which is, hundreds of other investigators and coordinators and people who've really done the work. So we'll start by acknowledging them too. So we want to talk today about this specific Prepare 2 trial, embedding pragmatic trial into clinical care during an emergency procedure. Derek, next slide. So Derek and I are both lucky enough to be funded by the NHLBI, and we have no conflicts of interest relevant to today's discussion. Next slide. This is the overview of the talk today, that we're going to be talking about this single trial, the Prepare 2 trial, and we're going to walk through the background, rationale, design, results, and discussion, kind of alternating sections like you would, but it's going to have two focuses as we go through, one of which is kind of what is this trial about for the clinician? And it's specifically asking this question of, does an IV fluid bolus prevent severe hypotension during emergency intubation? But then the second half of each of these sections is going to be thinking about, for the researcher, what are the nuts and bolts of how we actually embed an RCT into clinical care during an emergency procedure. Next slide. So I'll start with the background for this. So Derek and I are both critical care physicians, and emergency tracheal intubation is one of the procedures that we do in our practice. And emergency tracheal intubation is something that 2 to 5 million adults in the United States each year undergo. And at the time of that procedure, about 3 in 4 of those patients are comatose or unconscious, and about 5% of them are in cardiac arrest. And oftentimes these are patients presenting to the emergency department for whom no family is present. And this is an emergency procedure. So the median time from the clinician's decision to intubate till drugs are pushed for the procedure is about 5 minutes. So you can see why this is an important procedure, but also one that's challenging to research. And this is a slide that kind of thinks through all of the decisions that a clinician makes during a single emergency tracheal intubation. So all of these choices between two available options have to be made for every one of those 5 million intubations in the United States each year. And so those are choices like, should I use a fluid bolus or not? That's what we'll be talking about today, but it's, should I use a video laryngoscope or a direct laryngoscope? Should I use ketamine with its risks of adrenal insufficiency? Etomidate with its risks of adrenal insufficiency or ketamine. All of these practical choices between inexpensive available options have to be made for every single intubation. And when Derek and I started training to do intubation, the total number of randomized trials ever performed evaluating emergency tracheal intubation was 1. So 5 million patients a year, dozens of decisions that must be made, 1 trial. So that means none of these decisions have rigorous evidence that tells us which of these are best for patients, or at least that has been historically true. And that's a problem. And as we think about this, we think about the problem that comes from that being arbitrary variation in clinical care. And I'll explain what I mean by that. So you have a patient with a common condition like respiratory failure requiring tracheal intubation, and you have at least 2 available therapies, and rarely you have evidence that one of those therapies is best for that patient. And that's great. You breathe a sigh of relief, you administer that therapy, and you move on. But 95% of the time, clinicians, no one knows which of those treatments would be best for that patient. But the problem is you still have to choose one. So you make an arbitrary decision. And when I say arbitrary, I just mean anything that's not based on knowledge of what will produce the best outcomes for that patient. So arbitrary might mean that I trained as an internal medicine and then pulmonary critical care. So I do this because that's what my specialty does. And the same patient being intubated by an anesthesiologist might be managed differently, or it might be arbitrary because different regions of the country do things differently, or arbitrary because of what's on the hospital formulary. Anything that is not based on knowledge of what's the better of the two treatments for that patient. And why is that a problem? Because after that arbitrary choice is made, the patient still receives one of those two therapies. They still experience any of the benefits and risks of those therapies, but we're not learning. We're not watching, those experiences and risks and benefits don't further knowledge and improve care for that patient in the future or for other future patients. And so this problem of arbitrary variation in clinical care, increasingly our focus is trying to solve it by replacing that arbitrary variation with random variation or structured variation in the context of a clinical trial. So it still starts with a common condition like tracheal intubation, two available therapies, and we don't know which is best for that individual patient. But instead of making an arbitrary choice, we are trying to find those moments of arbitrary variation, acknowledge the uncertainty that exists there, and allow that to be an opportunity for randomization. And so patient still receives one of the two therapies, still experiences the risks and benefits like they would have in clinical care. But now we're watching, our eyes are open, knowledge is gained, the care for that patient in the future is improved, and for future patients is improved. And so that's the large scale background. And Derek's going to now talk us through the background of the specific question of fluid bolus versus none during emergency intubation.
Yeah, thanks, Matt. So circling back again to what Matt mentioned, emergency tracheal intubation is very commonly performed, but it's also, despite how brief it is, this is a roughly 2-minute procedure on average. It's a period of very intense risk for critically ill patients to experience a number of complications, some of which might impact their eventual outcomes. And so despite how commonly we perform it and how brief this procedure is, we think it's important to test questions around how to optimize this procedure. The risk of this procedure is distinct from that you might expect in an operating theater, another venue where patients are commonly intubated tracheally. In the operating room, the patients are selected and also optimized as much as possible before the procedure is performed. And an incidence of severe complications has been reported to 1 or 2% range. Whereas in the critical care settings, such as the emergency departments and intensive care units, even if you only look at severe hemodynamic sequelae of tracheal intubation, such as peri-intubation, profound hypotension, cardiac arrest, or death around the time of the procedure, you can appreciate here from this graphic that incidence is very much higher. It's been reported as high as 40% in some cohorts. And so this is a time when we predict that patients are likely to decompensate. And in fact, by virtue of the fact that they're undergoing tracheal intubation, they actually have decompensated. There's a reason we're placing the tube in them. You can appreciate then why these patients might be at risk for adverse events. And this gets us to an important outcome that's commonly measured in critical care medicine called cardiovascular collapse. Now, there's no consensus perfect definition for this, but this outcome is meant to comprise all of the severe manifestations of hemodynamic sequelae of tracheal intubation that are thought to be important enough or profound enough to be likely to impact patient eventual outcomes, and therefore important to the clinician as well. And a commonly used definition, which is the definition we'll be using for the studies that we're discussing today, is shown here. The definition of cardiovascular collapse is meant to is a composite of the occurrence of any of the following: a systolic blood pressure reading below 65 millimeters of mercury. So that's not a typo, that's a systolic blood pressure that low. Or the requirement for new or an increase in vasopressor drug therapies in the immediate minutes surrounding the tracheal intubation procedure, or more profound manifestations of hemodynamic complications or decompensation, such as cardiac arrest or death within an hour of the procedure itself. Importantly, this outcome has been validated and independently associated with in-hospital mortality in a number of studies, including our own, but each element of it has also been independently associated with in-hospital mortality in a number of papers. Why do patients experience cardiovascular collapse during tracheal intubation? Well, a number of mechanisms may underlie this. A few are shown here, including the decrease in venous return to the heart as a consequence of the application of positive pressure ventilation, which is part of tracheal intubation, sometimes during the procedure and sometimes immediately afterwards. But it's part and parcel of putting a patient on a ventilator, and this is known to decrease venous return to the heart. Also, there are effects of the anesthetic sedative drugs administered during the procedure on vascular tone. And just by virtue of the fact that we have to induce an unconscious state to facilitate the placement of an endotracheal tube, patients release less of their own endogenous catecholamines, and all of these may potentially be mitigated by augmenting cardiac preload through providing a prophylactic pre-intubation fluid bolus or bolus of crystalloid fluid. For that reason, this intervention is commonly used and commonly recommended. The intravenous infusion specifically of 500 milliliters of crystalloid beginning prior to induction and completed as rapidly as possible is thought to be or has been reported to be given about half of the time in patients undergoing tracheal intubation in a critical care setting. And this is also widely recommended. So the use of a 500 milliliter fluid bolus is specifically recommended for prevention of peri-intubation hypotension and other cardiovascular outcomes or complications by a number of guidelines, including the two shown here, which are specifically dedicated to patients undergoing this procedure in an ICU setting. However, prior randomized trial data to support this practice is sparse, and to our knowledge, prior to PREPARE 2, the study we'll be discussing shortly, really was limited to a single trial that we had published in the Lancet Respiratory Medicine in 2019, testing this question, which we call PREPARE, and I'll refer to it as PREPARE 1 just to distinguish it from PREPARE 2, which is the new trial we're going to focus on today. The PREPARE 1 trial was conducted in the United States across 9 ICU centers, and it tested the effectiveness of a 500 milliliter crystalloid infusion initiated prior to induction for preventing cardiovascular collapse. And as you can see here, overall, this trial showed no benefit from fluid bolus at prevention of cardiovascular collapse, either overall or any of its the composite endpoint elements that we've discussed already. This trial was actually stopped for futility after enrolling 337 patients. However, when we looked for potential effect modifiers that might predict patients who were more likely than others to have experienced benefit in this trial from provision of fluid bolus, we noticed an interesting consistent pattern that subgroups of patients who were exposed to earlier or more intensive positive pressure ventilation modalities, namely non-invasive ventilation or bag mask ventilation that was applied earlier in the procedure, these patients seem to be uniquely benefited from provision of fluid bolus. And this, as I alluded to earlier, is an interaction, a co-intervention that might have some physiological plausibility because the application of positive pressure ventilation to the thorax is known to reduce cardiac preload, and therefore augmenting cardiac preload by providing a fluid bolus just before you do these co-interventions conceivably could predict or enrich for a patient population that does benefit from fluids. Furthermore, at about the same time in the New England Journal of Medicine, we published the PREVENT trial, which suggested to us that this should no longer be a small subgroup of our population who are given positive pressure ventilation earlier in the procedure, but that it should be our default strategy for taking care of and placing a tracheal tube in ICU patients, because the PREVENT trial found that applying a positive pressure ventilation modality was effective and appeared to be safe for preventing severe hypoxemia. And so To summarize where we are now in a trial of all-comer ICU patients undergoing tracheal intubation, the administration of a fluid bolus in PREPARE 1 was found not to be beneficial. However, we have these provocative subgroups that seem to be representative of the way we now perform tracheal intubation, who seem to benefit, or had the appearance at least of benefit, from provision of fluid bolus. And we felt this justified the design of a new trial to specifically address this question more definitively. And so our research question was whether an IV fluid bolus would prevent severe hypotension and other manifestations of cardiovascular collapse during emergency intubation. And with that, I'll hand the slides back over to my colleague.
Yeah, so thank you, Derek. So when approaching this question of does this administration of an IV fluid bolus prevent cardiovascular collapse, and thinking about how you would design this research, and we're going to talk about the trial design for the next several slides, some of the major challenges to this design are that time to intervention between knowing that somebody needs to be intubated and the completion of the procedure of less than 5 minutes, and the fact that research personnel are almost never physically present during this procedure, or very rarely. So how do we design and conduct an RCT that answers this question that's happening, choice being made 5 million times a year with those constraints? So next slide, Derek. We're going to talk about the design. Next slide. So PREPARE 2, the trial design, was a multi-center parallel group patient-level randomized trial comparing a fluid bolus versus none among critically ill adults receiving positive pressure ventilation during intubation. So it was conducted at 7 academic intensive care units across the United States, and it included adults undergoing tracheal intubation with sedation who were receiving positive pressure between induction and laryngoscopy, or which that was planned, and it excluded pregnant patients and prisoners because of regulatory considerations, not because the physiology is expected to be different. It excluded patients for whom intubation was too emergent to safely perform study procedures like randomization, and it excluded patients for whom clinicians determined that either a fluid bolus was needed or a fluid bolus would be contraindicated. And the piece I would emphasize on that from just the research perspective is just highlighting how simple those eligibility criteria are, that there are 2 inclusion criteria and 3 exclusion criteria that could reasonably be read during an emergency to confirm the presence or absence of those criteria. So few in number and simple in design. Next slide. The trial was conducted with waiver of informed consent. With regard to the minimal risk determination, both of these treatments, a fluid bolus or no fluid bolus, are commonly given to patients in care. In current clinical care, about half receive a fluid bolus, half don't. Both are interventions to which the patient would likely have been exposed, even if not participating in research. No definitive prior data suggests clinical outcomes are better with one approach compared to the other. And importantly, both treatments were consistent with optimal care for that individual patient from the perspective of the treating clinician, who's actually the one at the bedside evaluating the patient. And otherwise, that patient's excluded by that final exclusion criteria. In addition to minimal risk criteria, we think about the impracticability of obtaining informed consent prior to emergency intervention like this. And so 75% of these patients are comatose at the time. Surrogates are frequently absent, and that 5-minute interval or less from the decision to intubate to the start of the procedure is likely not enough time for a meaningful informed consent discussion. So this trial is performed under waiver, and then information is provided to patients and families through an IRB-approved informational document describing the research, the participants' participation in the research, and then providing contact information for the investigators for further questions or concerns. Next slide. How does the randomization and blinding occur? So allocation is concealed until the time of enrollment and randomization. Patients are randomized in blocks of 1-to-1 to fluid bolus or none, in blocks of 2, 4, and 6, stratified by site. And these, the way this occurs practically is that opaque envelopes with the randomization inside. The eligibility criteria on this timeout or this hard stop on the outside, that the envelope cannot be opened without reviewing those eligibility criteria out loud with the team, contain the randomization, and those envelopes, the randomization envelopes, are physically located in each study site with the tracheal intubation equipment. So if there's an airway cart on the unit, which would be required to do any of the steps of the procedure, the envelopes are physically with that airway cart. Next slide. Once the eligibility criteria are reviewed and the patient is enrolled and the envelope is opened, inside is the study group assignment with a really simple guide to performing the tracheal intubation procedure using that assignment. So the fluid bolus group is shown on the left here. So instructing the clinician to hang 500 milliliters of IV fluid by gravity with pressure bag or squeezing it in, and then to begin the procedure anytime after the fluid is started and complete the 500 milliliters. And on the right is the instructions for the no fluid bolus group. So very simple instructions that are the same every time, involve pictures, and can be implemented by clinical staff, nurses or physicians during the intubation procedure. Next slide. Data collection. So in addition to data from the electronic health record on comorbidities and acute conditions at baseline and then clinical outcomes, the key data around the procedure were captured on this single form that was also inside the randomization envelope. And so a site-specific observer who are trained in this form collect this data. At many sites, that's a charge nurse. At some sites, there's a second physician involved in this who's performing this form, but it's someone who clinically is familiar with the tracheal intubation procedure and collecting vital signs, but has no role in the emergency procedures, not clinically caring for the patient in that moment. The top piece of this is filled out by the observer during the procedure, watching each of those data elements, and the bottom piece is filled out by the person who performed the procedure immediately afterwards. Next slide. As Derek has already mentioned, we used this primary outcome of cardiovascular collapse that had been used in prior trials. Next slide. And the sample size, our initial sample size in the design of the trial, was 750 patients using a power of 80%, a type 2 alpha of a two-sided alpha of 0.5, a incidence, the primary outcome of 25%, an absolute detectable difference of 8.75% absolute, which is a 35% relative risk difference, and anticipating less than 5% missing data. As we try to do for many of our trials where it's logistically feasible, we ask the DSMB at the interim to ensure that the anticipated assumptions around the event rate in the control group are observed in the trial so that we don't end the trial and have inadequate power to detect our planned relative risk reduction. And in this trial, as in several of our prior trials, the DSMB evaluated that event rate in the control group, and without giving any information, the investigators recommended an increase in the sample size of 315 patients, or 42% increase at the interim, to a total sample size of 1,065 patients in order to ensure the trial had the planned power that it started to detect that 35% relative risk difference. Next slide. The statistical analysis, the primary outcome, so this was an intention to treat analysis. So the only patients withdrawn from the trial after randomization are 2 who were discovered after enrollment to be prisoners. The primary analysis was a chi-square test, so an unadjusted test comparing those randomized to fluid bolus to those randomized to no fluid bolus, and things were expressed as an absolute risk difference with confidence intervals between those 2 treatment groups. Next slide.
And I think this is where I take back over, Matt. And so we conducted this trial from February of 2019 with a roughly 6-month pause during early COVID until final enrollment on the 24th of May, 2021. And follow-up for all of the data was complete on the 21st of June, 2021. We screened approximately 1,600 critically ill adults undergoing tracheal intubation in an enrolling unit and excluded about 500 of them. Far and away, the most common reason for exclusion was that the procedure was undergone too urgently to complete even the minimal trial procedures and randomization process itself. Importantly, we want to highlight that 27 patients, which is 1.7% of the total screen population, were excluded on the basis of fluid bolus being felt to be required by the intubating provider. This left us with 1,067 total randomized patients, whom, after excluding the 2 patients who were discovered to be ineligible by virtue of incarcerated status after randomization, we had 538 patients in the new fluid bolus arm and 527 in the no fluid bolus arm, who were included in the intention to treat primary analysis. Patient characteristics after randomization were well matched and generally reflective of the critically ill population that we were trying to test. Notably, the majority of patients were intubated on the basis of acute respiratory failure. About 1 out of 5 patients in each arm was on vasopressors and hemodynamically unstable at baseline. Almost 2/3 of patients in each arm had sepsis or septic shock. And the majority of patients were intubated using etomidate as the primary anesthetic induction agent. Compliance with study intervention or assigned intervention was very high. Specifically, 99% of patients randomized to the fluid bolus arm had a new fluid bolus initiated between enrollment and induction, and 99% of patients randomized to no new fluid bolus had no new fluid bolus initiated between enrollment and induction. We also wanted to measure not only the nominal compliance with the intervention, but also the quality of delivery of that intervention. And so this trained independent observer was also monitoring and recording the volumes of fluids given at the various assessment time windows of the procedure. And we were gratified to find that by the end of the assessment window, the vast majority of patients had received the entirety of the assigned intervention. So we had 99% compliance with group assignment, despite the limitations Matt's highlighted earlier during this emergency procedure, at which study personnel are generally not present. And so at this point, we've been testing a question that matters to investigators. It matters to clinicians. We've been studying it for 5 years. This is the second trial, and we've now enrolled almost 1,100 patients into PREPARE 2. And what did we find? So the occurrence of cardiovascular collapse was 18.2% in the no fluid bolus group, and the incidence was 21% in the fluid bolus group. This is an absolute risk difference of 2.8%, which is not a statistically significant difference, but it bears noting that the point estimate direction does not favor fluid bolus. Not only was the overall rate of this composite endpoint similar between groups, but also the rate of each element of this composite endpoint appeared to be similar and was statistically unchanged between fluid bolus and no fluid bolus. We also measured a litany of potential effect modifiers, and shown here are a couple of important ones that you may be curious about, such as the presence or absence of sepsis or requirement for vasopressors or inotropes at baseline. And we found no subgroup that appeared to be benefited from providing a fluid bolus for prevention of cardiovascular collapse. In terms of other clinical outcomes that may be important, our sole pre-specified secondary outcome of 28-day in-hospital mortality was similar between groups at around 40% in each arm, and also ventilator-free days, ICU-free days, the nadir of systolic blood pressure during the tracheal intubation procedure, and the change in systolic blood pressure from baseline during the tracheal intubation procedure were all similar between the fluid bolus and no fluid bolus groups. So to summarize where we are now in the second trial, PREPARE 2, we've enrolled over 1,000 patients into this study with 99% protocol compliance. We've administered a fluid bolus to patients during emergency tracheal intubation, but found it not to be effective for preventing cardiovascular collapse, with an incidence of that outcome of 21% in the fluid bolus arm and 18.2%, if anything, slightly lower in the no fluid bolus group. Furthermore, there were no differences in clinical outcomes, including in-hospital mortality at 28 days. We feel that some of the strengths of this study include its conduct at multiple centers, the enrollment of a severely ill population. We do feel like this is the population of patients we wanted to know whether or not fluid bolus was effective in, with a mortality of about 40%. The collection of trial endpoints by an independent observer with no missing data for that primary outcome, and a high rate of protocol compliance. However, the study also has limitations, and among them are the fact that cardiovascular collapse is a surrogate outcome that in and of itself may not be meaningful to patients. And also, this was studying specifically the effectiveness of fluid bolus for prevention of cardiovascular collapse, and may not inform the other uses of fluids, such as rescue fluids, even in similar circumstances. So this raises the question of why the fluid bolus didn't work. It seems like it ought to work. We had a prior study suggesting that in the target population of this trial that was enriched for potential to benefit from fluid bolus, that it would work. And so I think that you should ask anytime a study finds something not to be effective, certain questions about that trial, and I'll try to answer them for this study. I think the first question is whether or not we enrolled the correct patient population to study this. And there's different parts of this question. Did we enroll patients likely to benefit from fluid bolus administration in the first place? Well, we did prepare to use the predictive enrichment strategy based not only on physiology, but also on prior randomized data to target patients who appeared most likely to experience benefit. Furthermore, there was no evidence of benefit from fluid bolus overall or in any subgroup that we could identify of patients. So it seems unlikely that we were missing or not focusing on a subgroup that would have benefited. Did we exclude patients who would have benefited? Again, the answer seems to be no. We only saw 1.7% of the screened population excluded on the basis of a fluid bolus being felt to be requisite by the physicians caring for that patient. And lastly, did this trial enroll patients who were likely enough to experience the outcome? And we think we did. There was a high event rate. Cardiovascular collapse of 20% is almost identical to what we'd seen in the PREPARE 1 trial. And also we had a population with similar overall mortality of about 40%. Furthermore, even when we looked at patients' baseline risk of experiencing cardiovascular collapse, we were unable to identify a range of patient risk, either high or low risk of experiencing the outcome, who appeared to benefit from providing fluid bolus. Another question you may ask is whether or not we achieved adequate or real separation between groups. Did we perform a trial? Did we assign the intervention effectively? So the first part of this question is really whether the intervention itself is the right one or a reasonable one to answer this question. The 500 milliliter crystalloid fluid bolus was chosen for this trial in part because this is a volume that has been shown to increase cardiac output or to affect it. It is the most commonly delivered volume of fluid in clinical practice. It is the same volume of fluid that was used in prior studies, including the trial that suggested benefit in this positive pressure subgroup. And it's the same volume that's recommended by guidelines. The next question is whether or not we delivered that intervention effectively. And again, the answer is yes. The median volume of fluid given during the assessment window was the entirety of the assigned intervention of 500 milliliters in the fluid bolus group and 0 milliliters in the no fluid bolus group. And I'll also mention, as a clinician who enrolled in this trial some of my own patients, This is a difficult intervention to deliver in a timely fashion and fully during the tiny window of time that you have to prepare for this emergency procedure. Typically 4 to 5 minutes of lead time is all you have. And so it actually was difficult to get IV access consistently, get the fluids ready, have someone there to deliver them rapidly. To do that consistently, even in the context of a trial, was challenging. And so while it is conceivable that 500 milliliters isn't a large enough volume, it certainly, I would wonder whether a larger volume would even be practical or useful. So it may be a moot point. You may also ask or wonder whether our sample size was too small. To ensure that it was, we pre-specified a sample size recalculation during the interim analysis on the basis of, while we remained blinded, on the basis of a smaller than assumed rate of the outcome in the control arm. Furthermore, the effect estimate didn't suggest that we were just underpowered to see a benefit because it favored the no fluid bolus group, and there was no suggestion of benefit in any subgroup or in any secondary or sensitivity analysis. And so overall, we've now conducted 2 trials over 5 years. In the PREPARE 1 trial, we found that the effect of a 500 milliliter fluid bolus was ineffective overall for unselected ICU patients undergoing tracheal intubation. And in PREPARE 2, when we focused in on this provocative subgroup who were treated with earlier and more aggressive positive pressure ventilation during the intubation procedure, and also a much larger study, we again found that the rates of both the composite endpoint and also the elements of this endpoint were strikingly similar to PREPARE 1, and there was no benefit from fluid bolus. And we feel like collectively this information, or these 2 trials, are compelling evidence against the routine use of fluid bolus for this indication. These data were recently published in JAMA, and if you're interested, would point you to our primary manuscript, which came out in June of this past year. And our conclusion, our clinical conclusion, that among critically ill adults undergoing tracheal intubation, administration of a fluid bolus does not prevent cardiovascular collapse. And with that, I'll hand it over for just one slide to my colleague for the research takeaways.
Great, thank you, Derek. So I think as we're thinking back through this and looking forward to the discussion, there are probably 2 important pieces of this from a research perspective. The first is the ethical imperative to do this sort of work, which I just want to emphasize. So in our clinical care, in critical care, emergency medicine, and probably other places today, as we're doing this call, patients are receiving treatments that are ineffective or harmful, and that without RCTs, we can't know which those are, and we can't remove the ones that are ineffective or harmful from care. And that emergency research in our field has historically focused on a pretty small number of conditions. Cardiac arrest and stroke essentially neglected the most common treatments that patients receive as a part of their care. Tracheal intubation is an example of that. And so I think one part of our mission and what we hope to be working with everyone on is establishing the regulatory and logistical methods needed to examine in rigorous RCTs the full range of emergency treatments that patients are receiving in clinical care right now. So I think if we want clinical care in the emergency department and the intensive care unit to be safe and effective, we have to figure out how to do this. So the second piece is that embedding RCTs within emergency care, and in embedding each of the steps of the RCT, kind of like we talked about today, not just data collection or other elements, can help deliver the treatments in the manner that they're actually delivered in clinical care, right? So not in a highly codified research way, but in the context in which they naturally occur. It can collect the data which clinicians and patients use to base those decisions that they make in everyday practice. And it can enroll diverse and representative trial populations, and at a scale that we have the ability to potentially start to understand heterogeneity of treatment effect, or even individualized treatment effect, in a way that we can't in smaller, more explanatory trials. So I think our challenge and our goal for this is how can we improve acute care and emergency care through more broadly embedding trials like the PREPARE-2 trial inside of clinical care. So I think with that, next slide, Derek, we'll thank all of the people in our research network who contribute to make a trial like the PREPARE-2 trial happen. And we'll thank all of you for your attention. And I think we'll turn time to the discussion. And I saw at least 2 items that I think would be good. I'm happy to talk about, but Adrian, as the moderator, I'll let you start.
Yeah, so hey, thanks for a great presentation and kind of highlighting the different issues and possibilities here. And so there are some questions that I know you all have been attending to in the chat, but not everyone's able to see the chat. So we will review some of the questions that people put in so we can ensure we have a dialogue about these things. Let me first start off with kind of the so-called the big question is like, this is an important area, as you noted. There's high morbidity and mortality. There has been great understanding of, say, physiology over the many years, but not necessarily always the best understanding for evidence-based decisions. And so while there are many good clinicians out there that are doing their very best with the information that they have, if you had a choice of having randomized trial data, it certainly would make you more comfortable that you're making the right decisions. So the big question I have to start off with is that you nicely kind of showed 2 examples of things that happen every day that seem like relatively simple and straightforward. But what's a determination in terms of like, hey, we can do all these things in this randomized setting with, again, getting the waiver of consent. And so I'll just use the fluid bolus as a fluid analogy here. Is that like, hey, that seems relatively straightforward, but let's extend it a little more in terms of, well, what if like there's something that had perhaps, maybe more risk to it? What if it was antibiotics? What if it was some other drug? For instance, how do you draw the line? What's the determination of that? I won't say vaccine, but let's imagine that. Like, what if it was a vaccine that eliminated any critical care nosocomial infections as a multivalent critical care vaccine?
Adrian, if you've developed that, put it in the chat, let us know. So I'll start with that. So I think there are a couple of things. One of which is kind of the ethical framework, one of which is the regulatory consideration. I think we've emphasized throughout the talk that Derek and I only do comparative effectiveness research here. The only things we're looking at are 2 things that people are already getting. So this is a long way from drug development, device development, vaccines.
Let's for the purposes here, let's restrict our discussion to medical interventions that are available. So approved products for something, or interventions that are available to I'll just say typing and order in Epic. So
I think to conduct a randomized clinical trial comparing 2 interventions in critical care or emergency care for patients who it's an urgent procedure, emergent procedure, there are only 2 basic options, one of which, written informed consent is impracticable in those settings, right? So I think when thinking about how to do this sort of research, there's not a trial for cardiac arrest in the ED or a trial for emergency tracheal intubation for which written prospective informed consent is a reasonable option, because to do that would exclude 90% of patients and only enroll the 5% of patients who would not be the ones who are at risk of experiencing these events. So that's the starting point for the ethical and regulatory considerations, is that probably part of the reason that there's only been 1 trial when we started doing this, even though 5 million patients are intubated a year, part of it is that written informed consent is not one of the feasible options. So the 2 options that we have in our current regulatory environment are waiver of informed consent or exception from informed consent. And Derek is bringing up here how we kind of conceive of this when we think about this. And so this is the axis that we think about this on. And so on the x-axis, you have practicability. So you have on the left, where written informed consent is completely practicable. So you're in an outpatient setting, you have plenty of time to go over the informed consent document. The family member and the patient can ask questions, they can review it themselves in a quiet setting, and then they can provide informed consent that's meaningful. On the far right of this, you have probably the patients enrolled in the PREPARE 2 trial where they're comatose, there's nobody else there, and they need to have the procedure completed in the next 5 minutes. That's the x-axis. The y-axis, Adrian, which is what you're asking about, is the degree of risk. And I would say the degree of risk imposed by the research compared with clinical care. And I think it's not the degree of the risk of the outcomes, right? If you study mortality, but you do it in an observational retrospective study, that doesn't make that study more than minimal risk just because mortality is the outcome. And if you study critically ill patients, but you do it in an observational retrospective study, that study is not inherently more than minimal risk because those patients are experiencing more than minimal risk as a part of their illness. So that risk, when we think about this, what risk does the research impose compared to the risks of clinical care? And that's a spectrum that ranges from things that are clearly minimal risk at the bottom to places, and I think you might be exploring some of these where the research imposes clearly more than minimal risk. So new drug and device development, a vaccine that's new to this setting, I think are clearly in that category. And then based on where research sits in this matrix is how we think about what the most appropriate regulatory mechanism is for it. So for instance, we have a trial of ketamine versus etomidate for which the assessment was that the risk here might best be fit by exception from informed consent, which requires that the disease be life-threatening. It requires that there be the available treatments are unproven and that there's prospect of direct benefit. So there are a lot of things that go into EFIC that are not necessarily met by most comparative effectiveness research, right? That if you're comparing a video versus direct laryngoscope, you may not be able to make the assertion that there are not available treatments that are proven for that procedure. So for high risk or research where the research probably adds more than minimal incremental risk, we think of exception from informed consent as probably being the most appropriate mechanism. And for research where the patient was already going to get one of those two therapies and the clinician thinks either of those two therapies is totally fine and doesn't prefer one of the two of them, we think often that meets criteria for waiver of informed consent. And we adopt a lot of the same protections in waiver as are present in EFIC. So we often have information for patients and families that is provided afterwards that can look a lot like an informed consent document, but it occurs after instead of before. There are a lot of that kind of respect for persons and autonomy that can be built in regardless of the mechanism. But that's our framework. And I think the framework of, I don't speak for any IRB, but a framework for some of the IRBs that work through research in settings where written informed consent is impracticable.
Okay, we may circle back to some of this in a little bit here. I want to get to some other things here as well. So Nicole Redmond, if you want to unmute, you have a really important question. So I just want to give a little more context in that, if you're still there.
Sure, yeah, great, thank you both. So in disclosure, I used to be at UAB, so happy to see all of you before I joined NHLBI. And then actually while I was there, I was involved and very interested in work around those who have a history of incarceration, partly driven by my larger interest in health equity, given that there's disproportionate number of minorities who are incarcerated. And so how does that then create some structural barriers in terms of addressing disparities? So I recognize the complexity. And so I think as with, broadly, whenever we're thinking about inclusion and exclusion criteria, really not just saying, okay, let's just exclude them, but being thoughtful about, is there a true clinical reason to exclude this population, and going the extra mile to be sure that that we're including everyone. And so I think that's been a challenge that, they or people who have been incarcerated are maybe disproportionately represented in some studies, for example, HIV or infectious disease, and underrepresented in other types of studies, even though they are having, suffering from these conditions. And so I think it's just an important topic, even if you have to go through and get the OHRP approvals, but being really thoughtful about, are there really truly some considerations, but being mindful of the history of also, inappropriate inclusion. So, striking that balance. But thank you for letting me raise that point in that awareness.
Well, thanks. I'll comment and then I'll let Derek comment as this is critical. I think our perspective is the same as yours, which is there is no reason that a patient who's been incarcerated, or for that matter, a patient who's pregnant, or for that matter, maybe a patient who's 17 and 364 days should not be eligible for research like this. And so it is not a clinical motivation, it is regulatory. And I think we've spent a reasonable amount of time and continue to spend the time trying to find ways of working with the IRB and other regulatory bodies like the funder for a lot of this work is the Department of Defense, who we are interested in working with on this too. That I think that problem has to be solved. There's just not any ethical or clinical justification for it. It's simply the way those protections were put in place. And for these trials, as you point out, if a patient is enrolled and is not a prisoner and then becomes a prisoner 14 days after enrollment, that patient's data has to be removed from the trial. So it's a pretty extreme regulatory approach. So I think we're in agreement, and it's a goal of ours over time to make progress on that issue. Derek, what were you going to add?
I would just maybe clarify some of the subtext that, that one of the reasons for the regulatory additional sort of barriers to enrollment of prisoner populations is the possibility of coercive enrollment and coercive recruitment. And I think there is an ethical argument to be made that that's not relevant in the setting of a way of consent, and that and if anything, I think I appreciate Dr. Redmond's input that that we agree that maybe the predominant ethical concern in this setting is that we're not representing and studying those populations, and therefore, if anything, we might be under-treating and under-studying them in our settings because of some of these regulations. But these are way above my pay grade in terms of how to untangle.
And Nicole, the last thing I would point out, that just because it's a nice reference for people, that I think within critical care, the representativeness of enrollment and equity and availability of participation in clinical trials is a big issue. And Bram Rochberg of the Canadian Critical Care Trials Group just published a nice paper looking at all recent critical care trials and representation in it. And these trials, like PREPARE 2, come out with much more representative populations than those with a lot more eligibility criteria and other barriers to entry. And so I think while more work has to be done in that area, we're really enthusiastic about the idea of having pragmatic trials where the actual patients who would be cared for in clinical care are mirrored in the trial population.
All right, complex issue, but really important to see what we can do to make progress here. Just quickly, just one clarification: was there information that patients who are part of these centers know that they were part of a trial, or at some point, either at the beginning or at the end? Is there information displayed or communicated?
Yes. So after enrollment, there's an IRB approved document that contains information about the trial, information about the patient's participation in the trial, contact information for investigators, and contact information for the IRB. It has a lot of the trappings of a consent form, but is not a consent form because we've already experienced the risks and benefits of the participation that patients receive.
Okay, good. All right, let's see if we can get some other questions. Ankit, are you there?
Yeah, thanks so much for this presentation. I really enjoyed it, and think as a cardiologist and critical care doctor, I think it really spoke to me. Was interested in how you navigated the IRB process. I think you nicely laid out a framework around exemption for informed consent, but was curious when the rubber hit the road, what that looked like and how you navigated that, and if you used a single IRB.
So Derek, I'll start that and then you can jump in if you like. This trial used a mixed approach. So this was not federally funded under the mandate. So many of the sites opted to use a single IRB, but actually several of the sites opted to have it approved locally. And so this process of approval of waiver occurred at several different IRBs. And our primary IRB at Vanderbilt, which served as the SIRB, has a pretty strict firewall between investigators and the IRB. So we did not have any interaction with them. We submit the protocol and the application, and they internally debate it and think about the assessment. And I think that, I think we've over time had to develop kind of an ethical framework and regulatory framework for this. And so I think our IRB has thought a ton about this and continues to. And so this is not the first time our IRB is encountering trials in which it's written informed consent is impracticable. So I think that piece of it is an advantage to us, but I don't have a lot of insight into their the thought process. I can't speak on their behalf because we submit an application and they review it, and it's really distinct. And I think in the several other IRBs that reviewed and approved this, we didn't have a lot of interaction with them either. So I think that the things that we're really explicit about are what are the code of federal regulations currently, why we think we provide a lot of data that these interventions are already in use at the sites, and that the variation is not patient-centered variation, that it's variation based on providers or other factors, and that we are always careful to include exclusion criteria that mean if a clinician thinks one of these treatments is the right treatment for that patient is not enrolled. And I think those factors, seeing that there's variability, seeing that patients are going to receive these treatments anyway outside of research, and seeing that the research is not going to enroll patients for whom clinicians already know which treatment is best, that it has that even individual clinician equipoise component to the eligibility. I suspect those are important for the IRB consideration, but again, I don't know.
So that's great. I just want to see that. So it sounds like you wind up having to go with where there are preferences of the local institution, but and this is probably a little more complicated where there's more local institution involvement for sure. I want to see if I can get one more question, and this is such a great trial. So there was a comment about randomization, patient level versus cluster, essentially. So you made some decisions here. You had to. Why'd you pick the design you did in terms of patient level versus cluster?
So I would answer quickly, and then Derek, you answer too. So we love cluster randomized trials, but they're not a hammer, to which everything looks like a nail. I think we make it ourselves provide a good rationale for using a cluster level design. And I think that often has to include that the majority of patients in a clinical context are going to be undergoing that procedure. And so if it's oxygen administration or IV fluid, where 95% of patients in the ICU are going to get it, that makes a lot of sense. For a patient, for a trial that's delivered at the level of the patient, I think, and to a minority of patients in the clinical environment, we generally tend to think that patient level intervention is best. So how is it delivered in clinical care, and match the design of the trial to the delivery in clinical care? Derek.
Yeah, I agree. I could see I did allude to it, and I could see why they were asking, because there certainly was some difficulty in developing the ethos that fluid's always ready to deliver even before we know the randomization assignment of a patient. And so there are some processes of care that we had to build for this study that are similar to the way you might build processes of care for a cluster randomized study. But I think we simply had better power and more ability to tailor this intervention at the patient level through patient level randomization.
All right, and then in 30 seconds, what's your next big idea coming up?
Take it away, Matt.
Well, I think I would say I appreciate the invitation. I'm joining you all in a month to talk about our pilot trial of oxygen targets, which is a cluster level trial. So it would provide a nice contrast to this. And then I think from this network, the Pragmatic Critical Care Research Group, one of the things we've shown on that slide of unanswered questions in emergency tracheal intubation for a decade now has been choice of video versus direct laryngoscopy. And our almost 1,500 patient trial of that just closed 2 months ago. And so we look forward to knowing the results ourselves and then potentially coming back to share them with you.
Yeah, and I just want to reiterate our gratitude for the invitation and the opportunity to share this data with you, and for a really great question and answer session. Feel free to reach out to the smarter of us, Matt, or to me if there are any other questions we can answer with you, or any way we can help you with your local goals and research aims.
All right, Derek and Matt, thanks for joining us for Collaboratory Grand Rounds. We'll look forward to having you on again, and thanks for sharing behind the scenes what it takes. So hope everyone enjoyed this Grand Rounds. Please join us next week. We'll have an international perspective, pragmatic trials for children with congenital heart disease, insights from the NITRIC trial. We'll have a lead investigator coming to share what they did in that trial and that setting. So thanks all, and have a great weekend.